Good morning, everyone. These are my disclosure. So what we're talking about today. So we are talking about herbs, Ayurveda, Chinese medicine, and these terms are used with the more general concept of complementary and alternative medicine, which are a group of diverse medical and healthcare system, practice, and products that are not generally considered part of conventional medicine. So just to give you some numbers, this is a study. This table summarizes the study availables dealing with the use of complementary and alternative medicine in HIV-infected patients. As you can see from the table, there is quite heterogeneity, but the frequency, the percentage of CAM use ranges from 16% up to 95%. So this means that a very high number of HIV-infected patients use complementary and alternative medicine in their life. So which are the reasons for using CAM by HIV-infected patients? Number one is for general health and well-being. Two, improve immune function, increase energy, reduce anxiety. But they use CAMs also for specific pathological conditions such as lower cholesterol, treat diarrhea, etc. So, which are the types of complementary alternative medicine that are used by HIV-infected patients? As you can see from the figure, medicinal herbs is used by more than 90% of HIV-infected patients. So that's why today we are talking about herbs and the potential drug-drug interaction. But the most important information that we can retrieve from this study is that less than 1% of HIV-infected patients that use CAMs inform their healthcare providers of CAM usage. And this is a big issue because if you want to understand potential drug-drug interactions, you need to know that your patient is assuming herbal products. So this is really an important topic. So other information from these surveys in the upper side, the basis for choosing the right CAM therapy, as you can see here, nearly 50% of the interview HIV-infected patients don't know why they choose their CAM therapy. And this is really another thing that this is important to consider. And if you go in the downside, the source of awareness about the type of CAM therapy used in less than 10%, this source was represented by healthcare or hospital personnel. So in the large majority, mass media, other patients, CAM practitioner, and etc. So the second point is what are the risks, the potential risk for the patients, for the HIV-infected patients of using complementary and alternative medicine? As you can see from this study published in 2007, the authors reported a highly significant associations between the use of complementary alternative medicine and the risk of non-adherence to antiretroviral therapy. So this is really an important point. And this was confirmed by another study published some years later. Again, if you look at the table and the last line, the adherence to antiretroviral therapy was nearly 90% in CAM non-users and 80% in CAM users. Again, they reported an association between use of complementary and alternative medicine and the risk of pure adherence to antiretroviral regimen. So other risks may be related to specific toxicity of herbal remedies, as in this case. In this study, the author reported an association between liver fibrosis and the use of traditional herbal medicine from Uganda. The use of these herbs was the strongest predictor of liver fibrosis. And the third risk is represented by drug-drug interaction, and this is the topic of my talk of today. So if you use herbal remedies, you may pay attention because this product may induce some important interaction with the antiretroviral and non-antiretroviral medications. So If you think about herbs and drug interaction, all of you knows that the top layer is Hypericum perforatum. There a lot of literature has been published in the past years dealing with this topic. These studies shows that there is an association between the content of hyperforin, which is the main ingredient of Hypericum perforatum, and the induction of cytochromial enzyme. And especially this induction relates to cytochrome 2C19, 3A, 2A1, but not only cytochromial enzyme, but also transfer protein, as in the case of P-glycoprotein. Which are the effects? This has been studied nearly 20 years ago, but these figures clearly show that if your HIV infected patient is given Hypericum, the risk to reduce the exposure of antiretroviral medication range from 30 to 80%. So it's a really and highly significantly effect. Not only Hypericum, of course, there are other drug interaction involving antiretroviral medication and herbal remedies. This is the case of garlic supplement. So this study shows that 20 days of treatment with garlic supplement resulted in a 35 to 50% reduction in the Saquinavir area under the curve. So again, a highly significantly impact on antiretroviral exposure. And these data have been summarized in this very well done review published in 2008. The author shown here two types of warning. Number one is the warning that resulted in advice to stop doing so, and they relate to echinacea, garlic, cava, Hypericum, and a warning in which it is important to monitor for potential side effects: aloe vera, cat's claw, ginkgo, ginseng, licorice, etc., etc. So more than 10 years ago, we have very good results with the potential drug interaction involving antiretroviral medication and herbal remedies. This is another review published 10 years later in 2017. Again, drug interaction in HIV treatment dealing with complementary and alternative medicine. And as you can see here, there are also new drug interaction that involve also more new antiretroviral medications such as dolutegravir, elvitegravir, and maraviroc, and Humulus lupulus, Piper mesticum, glycyrrhiza, shark cartilage, yoimbe, that are herbal-based remedies that are used for different heterogenic conditions: sexual enhancer, sedative, antidepressant, anti-inflammatory, aphrodisiac, etc. But the key message is that with time, new evidence of potential interaction between herbal remedies and antiretroviral medications can be identified. And these are two more recently published case reports dealing with the new interactions that relates to the use of Equisetum arvense, also known as horse tails. These herbal remedies is mainly used as diuretic or for the treatment of digestive disorder, kidney bladder stone, hemostatic, astringent, so potential implications. There are a few data for its potential to induce drug-drug interaction, and for this reason, according to FDA definition, horsetail has been listed as an herb of undefined safety by the FDA. So the two case reports are quite similar. One is a male and one is a female. Both patients had a long story of antiretroviral treatment with optimal virologic control. And what they experience is that a few weeks after starting supplement containing horsetail, both patients experience an increase in the viral load. So the suggestion was to stop immediately horsetail, and viral load performed 1 month later stopping Equisetum resulted in a viral load resuppression. So this is an indirect evidence that the key player of this drug-drug interaction was Equisetum. The potential mechanism, hypothesis 1, is that Equisetum may induce cytochrome 2b6 because both patients were treated with efavirenz. Hypothesis 2 is that Equisetum may increase the renal elimination of 3TC, FTC, and tenofovir. Third hypothesis is that in some way equisetum may impair the absorption of antiretroviral medications. And the fourth one is that this drug-drug interaction may be related to adulterants. The key limitation of this study is that the authors did not present data on therapeutic drug monitoring of antiretroviral medication. But up to now, we have dealt with the potential interaction between herbal remedies and antiretroviral medication, but infectious disease physicians should pay attention also to non-antiretroviral medication, because as this study shown, the large majority of drugs that are given to HIV-infected patients are non-antiretroviral medication. So it is important to look also of this drug-drug interaction. And there are a lot of data showing that herbal remedies may interact with non-antiretroviral medication. This is a review published in Pharmacological Research in 2017. Again, it's ginkgo biloba, ginseng, hypericum, aloe, salvia. And this is another review published in 2016, and the list is even higher. So we have Acta racemosa, Catarancus, Vaccinium, Arpophytum, Echinacea, etc., etc. And the key mechanism for the observed interaction between herbal remedies and non-antiretroviral medication is via an induction or an inhibition of cytochromial enzymes. So the list of the potential herbal drug interaction is very high. But what about potential herb drug interaction involving not cytochromial enzyme, but phase 2 metabolism? This is a study published last year in Pharmacological Research, very well done study, in which the authors have reviewed the available literature and have shown that there are some herbal remedies such as Glycyrrhizia, Kaempferia, Auranti, Morus alba, Scutellaria, that are strong inhibitors of UGT, uridine diphosphate glucorosyl transferase, which is a phase 2 enzyme. So according to IC50 values, these are strong. This can be considered as a strong inhibitors of this phase 2 enzyme. And this inhibitory effect may be addictive or synergic. So it means that if you have an HIV-infected patient that is on atazanavir-based antiretroviral medication, and if you add, for instance, Glycyrrhizia, which is another inhibitor of UGT, the inhibitory effect may be addictive and the clinical implication may be highly relevant. So pay attention when you want to check an interaction between herbal remedies and antiretroviral or non-antiretroviral medication, that this interaction do not deal exclusively with cytochromial enzyme. And phase 2 enzymes inhibitions is important also because the most important class of antiretroviral medication that we have in our hands now are integrase inhibitor. As you can see from this figure, elvitegravir, dolutegravir, and bictegravir are mainly metabolized by UGT. So this means that the potential drug-drug interaction between this class of drugs and herbal remedies that have in some way some effect on UGT, it is must be taken into account, especially if you have a patient with a genetic background for which the baseline activity of UGT may be altered. There are, of course, some important tools that we can use to check for potential herbal drug interaction. These are 3, but probably if you surf in internet, you can find many others. These are the drug interaction checker from WebMD, specifically devoted to UTC and herbal supplements. This is the Stokely herbal medicine interaction and the MediHerb. But the key message is that you have online several tools to check for herbal drug interaction. Please use this tool because they are really important for the optimal management of your patients. And now I would like to spend the last 5 minutes of my presentations dealing with sharing with you my personal experience with the herbal drug interaction in HIV-infected patients from our outpatients service that together with my colleague Cristina Gervasoni, we have created 3 years ago. Actually, we have in our database more than 1,000 HIV infected patients on polypharmacy, and some of them are also given herbal remedies. So what we have observed in these years, this is a study that we have published a couple of years ago. The first 2 cases, this with the Orlistat, so it's not an herbal remedies, but the third one, which is a patient that experienced loss of control of HIV viremia while he was treated with the weight loss drugs. In this case, we have a patient that suddenly experienced a dramatic reduction in the atazanavir trough concentration to subtherapeutic levels, and asking him, we discovered that she was given Sinetrol. What is Sinetrol? Is a supplement that contains naringin, which is, so it's an herbal derived supplement. Naringin is extracted from citrus fruits, and it has been shown, there are a lot of literature showing that naringin can inhibit the activity of carrier protein, including P-glycoprotein, and this may result in impaired drug absorption, as the case that we documented with atazanavir. The fourth case, it's a male that again experienced loss of control of HIV viremia, and we have no data on TDM, but the fact is that we discovered that he started a few weeks before experience the HIV viral blip, that he started to be given Unabasic and Lipidum. So we focused on Lipidum. Lipidum is again an herbal remedies, contain phytosterols, mainly from psyllium extracted from Plantago ovata. And there are in literature some publications showing that psyllium may inhibit again the absorption of some drugs, as in the case that we observed. Another experience, personal experience, 2 years ago, we have a patient with a long good story of optimal virological control. Suddenly, the concentration of elvitegravir dropped from 800 nanogram per ml to 50 nanogram per ml, so a dramatic reduction. And we discovered that he started a few weeks before using CAT4-HIM, which is a thermogenic complex that he used to increase his muscle definition. And this supplement contains gugulsterons. Gugulsteron is a phytosteroid, so it's an herbal remedies, which is found in the resin of the guggle plant, especially in Commiphora mucul. And if you look in literature, there are evidence showing that gugulsteron can activate the pregnein X receptor, and this may result in the induction of cytochrome 3A4 and 5, which are the 2 enzymes that are involved in the metabolism of elvitegravir. So that's why we see this dramatic reduction in the elvitegravir concentration. Last case, it's a 42-year-old man, long-term history of HIV treatment, optimal virologic control. He was on treatment with dolutegravir, abacavir, and lamivudine. And we periodically measured the dolutegravir trough concentration, and the concentration were always largely above the minimum effective concentrations. So last year, the general practitioner prescribed him a dietary supplement containing Hypericum perforatum because of the treatment of persistent severe depression. So he was admitted to our outpatient clinics, and the first question that we have to solve was, should the dose of dolutegravir be changed now that the patient started the supplementation with Hypericum? We look at the drug summary product. As you can see from this figure, there are no studies specifically published dealing with this drug interaction, but the suggestion from the drug monograph is to double the dose of dolutegravir. So ideally, we should have increased the dose from 50 milligram once daily to 50 milligram twice daily. However, taking in consideration the very good exposure to dolutegravir trough concentration, we decided not to double the dose and to see what happens. This was what we observed. If you compare the dolutegravir trough concentration before versus concomitant Hypericum co-administration, you see that there are no significantly variation in the dolutegravir trough concentration. So probably we took the right decision when we decided not to double the dose. The second question was why the dolutegravir concentration are not reduced by hypericum. We have to go back to the information that we have, and dolutegravir is mainly metabolized by UGT, not by cytochromial enzyme. And there are a few data, but consistently these studies have shown that hypericum does not significantly induce UGT. So this drug-drug interaction was not expected. We don't know why in the drug monograph it was suggested to double the dose, because there is no strong rationale. The third question was, what would have happened if we doubled the dose as suggested by the drug monograph? So if you assume a linear drug pharmacokinetics, the trough concentration of dolutegravir could have increased from 1,400 to 2,700, 800, and this concentration have been recently associated with an increased risk of for the patient to experience neurological complication. So from this observation, there are, of course, important limitations. Number one is that we have no information on the hypericin content. But the fact is that if we have doubled the dose of dolutegravir as a drug monograph as suggested, we might have increased the risk of neurological complication in our patient. And this, if you want to get more information from this publication, this is the reference. Probably these examples show how it's a very important tool to monitor for potential drug interactions involving herbal remedies is by therapeutic drug monitoring. So this is the end of my conclusion. I would like just to end with these slides. As the incoming president of the International Society of Therapeutic Drug Monitoring and Clinical Toxicology, I warmly invite you to attend our meeting that hopefully will be held in Rome in 2021 from September 19 to September 22. Thank you very much for your attention.